So, great recording. Yeah, so hi everyone, nice to be with you and thanks for the invite. I'm going to, I thought I'd share with you the work that we've done over quite a long period now on a particular approach to early intervention for autism in the early years. And I wanted to sort of pitch this a bit to developmental scientists among you, with some mechanistic thoughts, and clinical scientists among you with some implementation thoughts. So I'm going to try and ride both horses, I hope successfully. I'm assuming that that's the composition of the audience. Anyway, I look forward to the Q&A afterwards, which as usual will be probably the most interesting, lively bit. But let me take you through this. Hold on. So I'm talking to you about our approach, which is really could be summarized as parent-mediated intervention. And you'll be familiar with this term, I'm sure, by now. But this is, as we use the term, intervention delivered with and through parents to enhance development in the neurologically vulnerable child. And what is a bit distinctive about this is that we only work with the parent, and we take a developmental model that says that there'll be a cascade effect. And I will, explain our thinking behind this and how we test it as I go through the talk. But the parent-mediated intervention is really what it says, is with the parent. Why do we do this and what's particular about it? Well, I think it does represent actually an important paradigm shift in the focus of intervention into the naturalistic developmental context of family. Traditionally, dating right back from the early radical behaviorism days of Lovaas et al. And the tradition that's flowed from that, the work really in autism intervention-wise has been very much traditionally, particularly in the US, of course, but also from that internationally through a direct behavioral modification intervention with children. And this kind of approach that I'm going to talk to you about here is really radically different to that. And I need to explain why we do it. Really, it's the context of normative social developmental theory. Based on a transactional account of known developmental processes, again, within neurotypical development. This is not about seeing parents as a problem, but seeing parents as co-partners in the solution. And of course, there are likely to be spin-off effects from this in terms of empowering and skilling and parents and instilling confidence that they can be the best parents that they can be and wish to be for their family, and improving family function. So all those things we hope would flow from this kind of approach. It's also efficient of professional time, because if we can induce the changes that we are intending to in the dyad, that is the therapeutic work. And that happens 24/7 then, and the therapist out with the therapist time. So the therapist is like the catalyst, the trigger, and then they can step back. This is not straightforward. This is not simple psychoeducation. It is not coaching in a sense that's normally used. It's quite a technical therapeutic intervention with parents, which is focused on reproducible impacts on their parental interactions with their child. And we do that in a reproducible way using video feedback techniques, as I'll show you. As I say, this is more than education and coaching, with which it can be a bit confused, because we're really aiming for a very specific developmental shift in the developmental dynamics around the child. And the theory is that will then cascade into child development. So this is just to give you an example of the sort of key element of the process in the parent interaction with the therapist. Firstly, we take a videotape of the parent with the autistic child in a naturalistic context with toys. And then we replay back this same videotape between therapist and parent. And I'll show you how that looks.
Exciting. Stop. Yes. Together. clever. Push. Stop. Nathan, stop. B5. B5. You found me. You're so clever. Clap hands. Actually, yes.
And here is the therapist on the right watching the video along with the parent.
And he got quite excited when I stopped to. Yes, the first time you stopped him. Yeah. I think that's right at the very beginning, and that's something that's really quite interactive because I think he realised I did that, and it made the game more fun. Yeah. Well, let's watch that bit again and see. Yeah, just see what it is. Let's have a think about what made it interactive. What were you doing? What was he doing? What signals was he giving you? Yeah. So that that's what I need to read. This means he wants me to be in this bit. Yeah. Yeah. Let's see what he does, because it's always quite dramatic.
So what I'd like to emphasize there is this is a sort of co-exploration with the parent. This is not direct therapy, although the therapist does have an agenda. This is a manualized, staged developmental process that we take parents through, but the actual moments in the video are very much co-exploration. What we're really after is the parents to discover for themselves their child. And that's, of course, the power of the video feedback. That's how it sticks in adult learning. And we think that's accounts for its effectiveness. So for the developmental science side, I just want to rehearse a little bit of what we think the developmental logic to this is and why we do it. So we're back to things that you know very well about, the importance of caregiver, infant and child interaction in the early years. In infancy, tuning of systems, joint attention, intersubjectivity, and particularly for our purposes here, the interpersonal platform for social and communicative development. So we take a very constructivist view of autistic development along the lines promulgated by Tomasello and others in terms of social development. And we use those same ideas for the autistic child. That's really the point. Empirically, the question is, are there perturbations, are there alterations in those early dyadic interactions consequent on early neurodiversity? And that's the key empirical question that would then underpin and, as it were, legitimize our approach. And we have done some of the basic science on this, as have others. And this is the work that we have done in the Manchester lab on parent-infant interaction and the perturbation from neurodiversity in high likelihood SIBs. This is within the basis study, high likelihood SIBs against normal likelihood SIBs, free floor play using the MACI, which is the instrument that we developed to specifically study this area. And we have these global ratings of parental function and child function. And just in brief summary, what we find is that our higher likelihood autism SIBs at 7 months, what we find in those dyads is we see changes at a group level in parental responsiveness. They become essentially more directive in the interaction. And this change is associated in itself with work that we did in parallel on atypical visual ERPs in these infants. So there was an association between the parental directiveness and the ERPs. So we got some sense that there's some linkage here to neurodiversity. Then when we follow the same sample up at 14 months, what we find is a continuation of those parental phenomena, but we also then see child changes in the dyad. And so these are a reduction in attentiveness, in affect sharing, and in mutuality. And these again are between group effects, but the important thing here was that those child dyadic effects at 14 months predicted autism development at 3. So what we think that this developmental empirical data suggests is that there is evidence for a transactional cascade towards divergent trajectories out of these dyadic perturbations early on. And that's essentially we think that the evidence is compatible with that idea. And that means that if we put in an intervention that is essentially focused on optimizing that dyadic environment, then we may be able to mitigate those trajectories. And this is not only an early intervention, which has a sort of developmental logic, we think, but it also acts as a developmental experiment. If we test this properly, actually we can test whether this developmental model holds up at a causal level, and I'll show you how we do that. So I want to take you through two ways we've implemented this approach. Firstly, the PACT intervention, which is the first thing we did at scale, which is a post-diagnostic intervention in the preschool years and early school years. And this is a 6 to 12 month program, as I say, focused on the developmental dyad, targeting parental awareness and communicative responsiveness. There's no active behavioral modification that we teach parents to do here. This is rather different to other kinds of PRT and other interventions of that kind in that sense. But it is staged from early communication precursors to later skills using video feedback. And as I said, we're looking for changes at this level with parent, which we think that the developmental logic will mean that there's a child change. And then critically, from our point of view, that if we introduce child change in the dyad, then they will generalize this out into other contexts and with other people. This, after all, is what children do generally in development. You know, they develop social competencies that they then generalize. And the key thing for us in autism is, can we show this in autism? Is this going to be particularly difficult or not? So this second step is the key one for us. It's, as those of you know the literature well, will know that it's relatively easy using various intervention models to change these, what we call proximal effects in the dyad. But actually, if an intervention is really going to have salience developmentally, I think we need to show this generalization across context and through time. So that's what we tested in the PACT trial. This was a large RCT in autism terms, 152 children. And I want to emphasize, these are quite significantly affected. These are children with core autism. Only 25% had phrased speech at the time when they were recruited, around sort of getting on between 3 and 4. So quite an impaired, if you want, quotes, group, not sort of just spectrumy. A 12-month intervention. And then what we did, which was pretty unique in the literature to date, is we did this long-term follow-up. So this is a 6-year follow-up from endpoint into the children were 10.5 years, so in middle childhood. So this was done in preschool through to middle childhood. We kept the randomization and blinding here, and we got an 80% follow-up. So we think that this is pretty unique as a developmental test. So we've kept the randomized experiment through over 7 years to this point and got a pretty good follow-up, and we've tested the outcomes using pretty much the same endpoint measures. So we published the results of these of the PACT and follow-up in a couple of Lancet papers that you'll probably be familiar with. They're some years ago now. But just to take you through the results, because they're salient for what I'm going to come on to say. As you remember, I say we have this cascade effect in theory from change in parental synchrony, as we call it, contingent response, through to childhood dyad and then childhood generalization. And that's how we test the intervention. So we test those 3 stages, and that's how we test the mechanism effects. So here is the effect of the PACT therapy on the targeted parental behavior, parental synchrony. This is treatment as usual, and this is the PACT intervention. This is midpoint, this is treatment endpoint, and this is follow-up. So you can see proportionally what a long follow-up period. So the headline here, this is from the Lancet paper, is that we get a pretty good kick of a treatment effect on parental synchrony. So the effect size here is about 1.26 at endpoint. which is, you know, a very substantial effect for a behavioral intervention. And what you'll see over time is that the effect seems to dilute out. We're not sure whether this is a measurement issue, because synchrony in middle childhood doesn't mean the same as synchrony when you're 4. That remains a slightly unresolved issue, and it may be that it's a measurement issue. It may be it's simply a washout effect. Here's the child dyadic impact or communication with the parents. So this is our second stage effect from the treatment. And remember, this is not directly targeted in the treatment. This comes as a direct result of the change in parental function. That's the only thing. And you'll see here, which is what you'll see is pretty classic over the studies we've done, which is you get a bit of a lag effect. So it's not such a big treatment effect, although it is actually significant at endpoint here. But what you'll see is that the change that we induce at endpoint sustains through the next 6 years. So that, when we saw that, we thought, okay, this is something really interesting, because to sustain a developmental treatment through this time where you've actually preserved the randomization of the groups is a pretty special thing to have done, as anyone who's done these developmental trials will say. So we've sustained some sort of change in the the child dyadic initiations. That's what we were interested in, how much the child's actually communicating with the parent. And then this is our key outcome. This is our primary outcome, which is the generalized change. And this is therefore how the child may have generalized that alteration in communicative function out into other contexts. And the way we measure that is through the ADOS. I'm sure that we could have some discussion when we have the Q&A about our outcome measures. This was always a controversial choice from the beginning of our work, because as you'll know, this is a diagnostic measure and not used for symptom change in treatment. Nevertheless, we had a logic for why we did it, partly because we could measure it rigorously, independently, and blind. And we thought that response biases in outcome estimations was such an important confounder in treatment trials. We thought that's what we wanted to do. It also proved that actually we could show change in ADOS, which was a benefit as well. But we could talk about, I'm very happy to talk about that in our Q&A. So here's our ADOS. CSS is the combined severity scale. And you'll see here we reduce, the PACT reduces severity significantly at endpoint. And again, importantly, crucially really, this effect to reduce the severity is sustained right through to follow-up. And that's over 6 years. And I'll come back to how we measure this. So we developed a way of measuring change over time, which was essentially the area between the curves here. And we used that as a way of estimating cumulative impact of change over time from treatment, which we think is an important kind of metric for long-term treatment effects. But I'll come back to that. We of course, did a whole battery of other measures, and parental language measure, MCDI, SCQ, the Autism communicative questionnaire, and the repetitive behavior questionnaires. These were all significantly improved at sustained improvement at follow-up. So all these parental measures showed significant effects too. The VABS and the SDQ were nearly at significance. There was a strong trend. And teacher VABS also nearly significant, strong trend. What we didn't show was an effect on the objective lab language composite. And again, we could discuss the reasons for that. That could be measurement insensitivity when you compare it to the strong effect on MCDI, or response bias, whatever. But we didn't get that, nor did it on the Dorber comorbidity. So that's our PACT trial. And we wanted to know, showing that it worked like that, we wanted to know how it worked. So we undertook quite a sophisticated mediation analysis, which essentially it uses the repeated measures that we're able to construct over time. But essentially what we're testing is quite a simple model that here's the therapy. This is the impact on parent behavior. This is the child behavior, and this is the generalization. And we want to see the relationship between these, but we use the repeated measures design to create latent variables for each of these. So those of you who are in developmental scientists may be interested in this technique and have a look at this paper. It's really cool paper from Andrew Pickles. So we use these repeated measures to both minimize measurement error, which is a big deal in these kind of measures we do, but also construct a latent variable, but essentially testing this model. And what we find is pretty striking, which is that the change in the child initiations in the dyad, so this is our second level, is very strongly mediated by this change in parental synchrony. In other words, the logic model of the therapy is supported by this mediation analysis. It is the parental synchrony that does this change. And we looked at all sorts of other parental communicative acts within our videos, and nothing really came up. So it's pretty specific to synchrony. And that was an important result for us. Even more important in a way was that it's this change in the ADOS result, that's the generalized social improvement in the kid, which I should emphasize affects not only the social communication, but also the RRB domains. It's the whole symptom and sensory sensitivities. So it's the whole symptom complex that is improved, and we've broken it down to show that this change in ADOS is almost completely mediated by this change in the child dyadic initiation. So that is really showing that something is happening within child here, which is allowing this generalization. And I think that from a developmental science perspective, that to me is a really interesting result, which I'll come back to. So that was our first sort of bit of work, as it were, on the PACT intervention. And now I just want to show you basically the same principle of work that we've done in infancy. So this is pre-diagnostic, prodromal, if you like, intervention in infancy to see if we could tackle these perturbations at the earliest stages before they became symptomatic. So PACT was post-diagnosis. This is pre-diagnosis. And we're targeting here these parent-infant interactions, as I mentioned before. We had a number of proximal outcomes, which were, co-occurring with that around the same time in the latter part of the first year. But our real target, of course, is downstream. What we're interested in is whether we can make a difference here that then feeds through into our three-year diagnostic assessment. So that's our intervention model for the prodrome. This is a true prodrome. Those of you who've read Tom Insel on this a long time ago talked about we need to move neuropsychiatry from reactive to behavioral phenotypes to proactive from early neurodevelopmental trajectories. And that's what we're really trying to do here. So this iBasis VIP infancy intervention is basically the same idea. It's parent mediated. It's the same thing basically as PACT, but we've adapted it particularly to infants at risk or infants with high likelihood. It's home-based. It's slightly shorter. It occurs over 9 months rather than 12. Very early, from 9 to 14 months. Daily practice plans for parents. And again, it's developmentally phased around these early developmental moments for the child, the sequence that we're familiar with from neurotypical development. But we have a big adaptation and focus on what early atypicalities we've learned about from baby SIB studies and how we could interact and help the the parents interact and accommodate to these divergences here. This is the key part of the therapy. I'm going to leave those videos just for the sense of time, but happy to play them after, it's just a bit of a pre-post on the interaction effects. But I'm going to just wish to show you the results, and we have the same sort of basic 3-level measurement test, exactly like PACT. So the trial is designed exactly the same as PACT in essence, that we're aiming to test this notional cascade, which is basically the logic model of the intervention. So here is our first go at this. This is the iBasis trial that we published back in 2017. And this is a relatively small trial. It was 54 children randomized within the BASIS longitudinal study. And we compared the children who had the iBasis VIP intervention with treatment as usual, which in UK terms at this time when we did the study was pretty much nothing. And so these are the results. And again, it's the same format as what I showed you with PACT. So here is the parental dyadic response. This is our proximal outcome, what we target. We want to get this, we wanted to improve, if you want, optimize what we call the non-directiveness, but it's equivalent really to the synchrony later on. And you'll see here that we succeeded. So here is the PACT, and this is the treatment as usual, which is constrained to the 0 line. So this difference between the curves here is what we are measuring as the cumulative outcome. And you'll see we get a strong treatment effect with synchrony. And again, as you remember with PACT, it sort of seems to fall off, although we do have a measurement issue. So at this stage here, we change this to a different measure. That may have made a difference, or it may just be a washout. But we do get this initial treatment kick with the parents. And this is the child's dyadic response with the parent, exactly the same logic. And you'll see here again a lag effect, just like in PACT, but it sustains itself. And so when we look at the area between the curves here, we get a significant effect over time, although you'll see that the point estimates are all like they're crossing 0. So this is not massive, but when you accumulate it, when you build it up over time, this is highly significant. And this is, sorry, oops. And then this is our symptom outcome. So this is the equivalent of the ADOS. We use the AOC as our primary for infancy here at endpoint. And then we shifted to the ADOS for these 2 measures here. And you'll see the same sort of result where you get this decreased severity, which sustains itself. Perhaps it's just washing out a bit at the end here. But if you look at the overall between curves estimation, it's highly significant. So what we're essentially saying here is we get this cumulative effect, which seems sustained, and that's partly speaks to the importance of following up these samples that I'll come back to, but also evidence of the treatment effect within development. Then, as you'll probably be familiar with, we published a replication of that trial from Australia with colleagues last September in JAMA and Pediatrics, and this received a lot of publicity, as you probably remember. And so very happy to talk about this again in the Q&A because it was an interesting result. Essentially, it's a bigger trial, so we doubled the size in the Australian replication. And the important thing for the replication here was that we used an indicative sampling. So rather than sampling by familial likelihood, i.e. in the SIB study, we here took community concerns. So we picked up the community worrying kids in the community at 12 months, assessed them on this instrument called the SACS, which works out pretty well. And we did the 5-month intervention. What it ended up with is that in this Australian replication, we did the intervention slightly later than we did with the UKI basis. But importantly, it's on this community sample, so that makes it much more appropriate, as it were, for a health service utilization. And then we had the diagnostic at 3 years. So just to show you here, part of the result is that we replicated here the effect on AOC-ADOS. And I just say with this replication, we really did replicate in the sense that we used exactly the same measurement system and analysis as in the UK trial. And so this graph here is basically very similar to the UKI basis, which shows you the reduced severity on AOC-ADOS and the significant effects cumulatively over time, area between the curves. Again, to say the point estimate effects are not massive. We're not talking about sort of massive sort of change here, but it's enough over time to make a cumulative effect. And we thought that was pretty much exemplified by when we had enough power to do the clinical best estimate of autism diagnosis at 3. So this was done pretty rigorously, independently blinded clinicians. So these were completely independent of the trial process. They had access to all data, including ADOS, parent-child interaction measures and other measures. And they assessed these kids against DSM criteria, and they had a consensus classification. So this is the sort of classic way that we do consensus diagnostic outcomes in these longitudinal studies. And what they found was, this was the headline in the publication, of course, is a 2/3 reduction in the clinical diagnosis at 3 in the treated group. And so 3 out of the 45 were autistic, above autistic threshold in the treated group versus 9 out of 44, 20% in the treatment as usual group. This is highly significant effect. And for those of you who are clinical scientists, the number needed to treat is 7.2, which is for an intervention, really persuasive. So this means essentially that you have to treat 7 families to reduce 1 autism diagnosis, which in kind of medical implementation terms is a strong result. I want to emphasize that these kids they came below the autism threshold, but they were still neuroatypical. So they still had neurodivergence, but they were not autistic by the accepted phenotypic definition. So this is sort of my key summary here, that what I think is really interesting cumulatively about this work, because we all know that the replication crisis in science generally, in psychology, and I just think we have replicated effects here that seem to me quite persuasive. So here is our PACT. This is the primary outcome on symptom severity. So we have our PACT pattern graph over time. We have our UK prodromal, and we have our Australian prodromal. And you'll see a remarkably similar pattern of effects on symptom outcomes. And this is busy, but it's just meant to show you that we also have quite a lot of replication on these more proximal dyadic effects in the parental synchrony across really 7 or 8 studies now showing the same effect. And these childhood dyadic communication, again, over in India, as well as in the UK and Australia, and in a number of studies in the UK. So this is really just to say these are really quite robustly replicated effects, in my view, over really a number of what we think are pretty rigorous trials. So to come to my final slides or so, what do we make of all this? Well, certainly, you know, we had a lot of interesting discussion with the autism community, professionals and others when we published the results last September, particularly showing the phenotypic reduction. And you know, we can talk about this more in the Q&A. I won't anticipate that. It was a great discussion. We leaned into it, and we got criticism, as I'm sure many of you will know, but I think this is meaningful. And when we were able to engage with the community, I think they understood what we were doing. Of course, this big headline thing of phenotypic reduction needs replication, but it's pretty obvious really that it's consistent with the dimensional change in ADOS severity. There's nothing really particularly remarkable about it. You change the ADOS severity enough, you're going to pull these kids below the autism threshold. But I think it's a meaningful change. I don't think it's just arbitrary. I personally take the view that phenotypic thresholds are there for a reason. They're not just total artifacts. We can just again discuss that. So I think this is a meaningful change. And it says to me, partly from a developmental science point of view, that this outcome phenotype is malleable. It's emergent, it's highly heritable, we know that, but it's malleable because and not just but I commit to it, model of early transactional development within autism means that the environmental contingencies and conditions interact with the neurodiverse givens to make the outcome phenotype. And, you know, that's an important thing for us to nail down and work out how that works. And of course, the thing about doing rigorous trials like this is that we can show from a developmental science point of view that that's true. That what a good trial like this is a developmental experiment. We do a experimental manipulation of the environment around the child in a focused way, and we show that the phenotype changes. So that proves causally, which you know, observational studies find it hard to do, that proves causally that the environment does impact phenotypic emergence. And I say that with conviction. I think the evidence is strongly supportive of that. And that, to me, is very important for developmental science. So we've got this early transaction between the neurodiverse brain and the social environment. And that's the theoretical foundation of our intervention. But I think it's the model that we need to understand neurodiversity at the moment. Of course, there are public health implications. And of course, there have been concerns from the community and some parents. And I'm not going to go into this for time, but bring it up in Q&A by all means. Some in the community felt it was an attack on autism identity. We strongly argued back on that to say, no, this is not behavior modification. We're not trying to wipe out autism. We do not do behavior mod in this treatment. All we do is we honor diversity, we maximize the environmental adaptation to diversity, we nurture it, and the positive outcomes are as a result of that. And I think when the community understand that, they realize that actually this is not an attack, it's a care and concern in an intervention sense. And anyway, that's how we've argued it. There's another argument, which is that if you reduce the diagnosis, then you're going to reduce impact to access to services which are tied to diagnosis. Yeah, and that's at some level potentially true, but that's just perverse incentives in the health system, which are fixable. So just finally to say that you know, these treatment effects are really not affected by social class, education, culture, or ethnicity. We've shown in a number of trials that we get these effects across all these, the spectrum of these variations, and we've had no real evidence of adverse effects. But we do have qualitative studies we published of patient experience, which are positive. Okay, I'm running slightly over, apologies. So this is just to, I won't go into this in any detail, but just to say that I think this replicated evidence gives us a handle for the first time to form a proactive and early integrated care pathway for autism through early development. And lots to say on this, which I won't do, but we put together this model for a developmentally phased pathway for young autistic kids. It's coming out in the Lancet Child and Adolescent Health next month, so you can have a look at it and our arguments in detail. But basically, we're saying we need a pre-diagnostic detection care, integrated detection care system, peri and post-diagnostic family-focused support with interventions that are known to really impact development downstream. Otherwise, you can't make a logic for this. And then we need a case management system to endure the care, because this is an enduring condition, provide step up when you need it, and carer management. We make the detailed argument for this in the paper if you're interested. But the focus is improving child function and family resilience, and step up care as needed later in development. And the two interventions I've highlighted here, the IBASIS VIP and the PAC, fit in at these levels. Now, I'm not saying these are the only interventions you could put in here. There's a big plethora of interventions out there, but I would maintain to you that these are the interventions with currently the best evidence to slot into these this kind of pathway, but happy again for discussion on that. So this is the health system change that we would need to make this responsible, this possible. And it's a big change from reactive to proactive care. And again, we argue it in the paper, and happy to have a discussion over time. So sorry I've overrun slightly, but my thanks to my wonderful colleagues who've done all this work with me over time. And here's some information if you're interested in further information or training or whatever. Thank you so much. Sorry, I've gone over a bit.